All attendees are in listen-only mode.
Good afternoon, everybody. I'm Andy Dwyer, working with Fight CRC in a joint appointment with the University of Colorado Cancer Center, and welcoming you all today to our webinar where we're talking about radiation treatment for colorectal cancer and how it works, what to expect from a medical point of view, but particularly engaging for patients to think about next steps in treatment and care. So we're really excited to go ahead and begin our broadcast today. On behalf of the entire Fight CRC organization team, I want to send a special thanks to all of the general and extensive team who've put together all of the moving parts to make today happen. So Sharon Worrell, who's the patient education manager, is going to be managing our Q&A after the session today. So thanks for all of Sharon's leadership and help. And a special thanks to Andrew, Danielle, and our entire comm team for all of their work in terms of following us along on Twitter, or social media, as well as Facebook today, and also the new intern, Elizabeth, who's joining. So really appreciate all the dedication and support to ensuring that we have great tools and resources. We'd like to make a great announcement today that Michael Sola, who's joining us today in terms of part of our leadership team, is made the announcement and really brought forth the real legit information that we are right around 100th webinar that Fight CRC has produced for patient education and support, and Michael has been a huge leader in ensuring this happens. So there's Michael Sola, who's oftentimes behind the scenes, but Michael's really been instrumental in making sure that this happens, and we want to send out a special thanks to all his dedication and support. And a picture of Kevin McAbee, who's also been part of our team in the past years, and excited for all of the people who've made all of the great work Fight CRC come to life. So we're really excited today. Thank you again for the entire team that we're presenting Dr. Michael Bassetti, who's from the University of Wisconsin. And a note that Mike has been very, very instrumental in a lot of the work that we've done with our research advocates with the University of Wisconsin over the last couple of years, or last year particularly, in concert with Dusty Deming, who's one of our medical advisory board board members. So we're very excited about having Dr. Bassetti today. Just quick note that the webinars are archived on the Fight CRC site, and as a special thanks for filling out any of the evaluation and giving feedback today, you'll get the much coveted and loved iHeartBooty bracelet. So follow us along again on Twitter. Thanks again to Andrew, Danielle, and Elizabeth for manning that post for all of the really sensational sound bites and information that are most salient based on today's work. Next slide. So just as a quick note, we've added this slide that in terms of the webinar and tech support, on the right side of your control panel, and looking ultimately right now, so if you look at the slide control panel can be adjusted using the orange arrow. We ask that if you go ahead and have specific questions, that you open that question box so that you can key in specific questions. So this gives you the step-by-step instructions. We want to just remind everyone that not all questions will be addressed, particularly if they're about medical or personal one-on-one care. We ask that you make sure and basically utilize your healthcare team based on your own specific question and need, and then note that all of the work that we're presenting today is really from a general education standpoint. And so just as a note that on time, we want to make sure that we're getting good questions, but just a little bit of parameters about the type of questions that we can ask. So just wanting to make sure that the bandwidth services, that you need to make sure that if you're having any of those problems at all, shut down, restart, or let us know if what issues you are having, and if there's something we can troubleshoot on our side, we will sure try to do that. So go ahead and slip to the next slide. And we do want to remind everybody that we are sensationally excited about all of the questions that you do ask. So please, if you can, any general themes, keep those questions coming for great discussion. Quick note that the Guide and the Fight has been revamped with Sharon's leadership and much of our team into 3 specific components, and we have that newly updated and downloadable for all of you. And that is free of charge, but want to make sure that you understand that most of that information has been updated. We parceled the information based on early diagnosis, business affairs, getting pieces in order, as well as the duration of treatment and thinking even longer term about palliative care as well as managing of symptoms. So a great resource available for everyone. And as you might have seen recently within the news and as well as the Fight CRC feeds, the late-stage MSS trial is up, running, and is getting a lot of publicity attention because it's really helping with inroads, particularly as we think about new advancements in immunotherapy for CRC patients. So just a reminder, 2 great resources that are definitely amongst some of our top picks, and we want to make sure that you utilize these, spread the word, spread the information, because we're really proud of what we're able to do for patients in support and education. Next slide. And as I alluded to earlier, we want to make sure that, of course, Fight CRC's materials are not a replacement for direct medical care. Please make sure to connect with your healthcare team if you have any specifics around emergency management of symptoms, anything around medical advice or even medication. And if there is an emergency, dial 911. But our support and materials are for general education and reference to be brought back with you and your healthcare team. Next slide. And so with that, I'm super excited again, as I noted earlier, that Dr. Bassetti is joining us today from the University of Wisconsin Cancer Carbone Center. And he's broadly trained as a radiation oncologist with a specialty focus on the GI cancers. And he brings a particular interest and expertise in thinking about really the very specific parameters of radiation and treatment, specifically for colorectal cancer survivors. So we're really excited. I know that we've heard a lot from Dusty Deming, their entire team, about the multidisciplinary approach in terms of treatment for providers, and we've gotten a chance to hear a little bit about their work. And so excited that we are able to focus on one area that they do exceptionally well in terms of the radiation care. And I will actually pass it over to you, Dr. Bassetti, to take it away in terms of the information you're providing us today. And a huge thanks for all of your commitment for today's webinars, as well as our research advocacy training and support program. So Dr. Bassetti.
Great, thank you. Okay, so hopefully you guys can all see my screen okay. So first off, thank you everybody for the from Fight CRC and for everybody attending. I'm honored to be here, and it's just exciting to get to present some of the treatment options we have from a radiation standpoint, as well as just to be involved in this webinar. First off, I just love the name Fight CRC because I feel like we advocate and fight for our patients every day, and it just reflects sort of the struggle that we have to try and improve cancer care, particularly in colorectal and rectal cancer. So the title I have here today is Radiation in the Treatment of Rectal and Colon Cancer. And I put it that way particularly because most of the patients that would have had rectal cancer may have experienced radiation, and many of the patients that have had colon cancer may not have. And so hopefully I'll highlight some of the uses of radiation and how it might fit into different aspects of care. So as they mentioned, I am assistant professor at the University of Wisconsin in Madison, and focus on GI cancers. And I worked very closely with the whole team here in colorectal cancer care. So just starting off with an overview of the presentation today, we'll talk a little bit about radiation treatment basics, and as well as rectal cancer treatment, and then metastatic colon and rectal cancer treatments and how radiation might fit into that care, particularly with respect to metastasis to the lung, liver, or brain, as well as ending the presentation with future directions of care, MRI-guided treatment and response assessment for an individual patient's response, as well as immunotherapy and how that may fit into microsatellite stable colorectal cancer. So just as a general overview, most of you who are at all involved as patients or advocates know that the 3 mainstays of oncology are chemotherapy, surgery, and radiation. And but that doesn't mean that's what it's limited to. Immunotherapy has really made dramatic inroads, and other treatments potentially make inroads as well. And but I think this highlights that coordination of the care often leads to the best outcomes. None of us can go this alone, and we really rely on our colleagues for their input and management. So radiation therapy, when I'm talking about today, there's definitely variations, but what I'm going to talk about is really high energy focused x-rays. So the same type of x-rays you get in a CAT scanner or all the imaging that patients have had, but they're really generated by machine. They're higher energy, and we can aim them where we would like. And X-rays damage the cancer cells' DNA, and that caused them to die. That's the simplest explanation. There's many other aspects of radiation therapy that come in, but that's the general way that it functions. So how does radiation fit into colorectal cancer care? So rectal cancer treatment, often patients who have locally advanced and potentially curative rectal cancer will undergo radiation treatment. Many other patients who have metastatic rectal cancer but need to get the rectal primary removed often will get radiation treatment as well. So let's start off just talking with rectal cancer. And I think that in order to understand the benefits of treatment, it's nice to have a little sense of what surgery is involved. So most patients with rectal cancer will undergo surgery as sort of their mainstay of treatment, as well as chemotherapy and radiation, potentially in advance or sometimes after surgery, and often followed by additional higher dose chemotherapy. But the surgery comes in different flavors, and it depends a little bit on where the tumor is located. So in this diagram, you can see that this patient has a tumor down here. So this is the colon, and as you get down to the sigmoid descending colon and then into the rectum. And with the tumor located here, the distance from the anus, where the muscles of the anus live that hold back stool, lets you walk around without leaking stool. If a tumor is located a far enough distance from that, the surgeons can cut above and below that tumor and then re-anastomose or reconnect the plumbing, so to speak. Often this step involves a temporary colostomy that then subsequently gets re-anastomosed. But that's the gist of it. So this would be a anal sphincter preserving surgery. And I'll just show you on a slice separate to this how this looks. So if we took a slice where the front of the patient sits where my arrow is here, and the back of the patient sits here to the right of the screen, they have a tumor sitting right here in the middle of the rectum. And what the surgeons really are concerned about is microscopic deposits of tumor in the fatty tissue surrounding that rectum, that area called the mesorectum. And radiation was often used after surgery or before surgery historically because it really decreased the issue with having a recurrence because of these deposits. Now, there was a major change in the type of surgery that's done for rectal cancer patients called a total mesorectal excision. And that just means that the surgeons cut along the fascial planes, this covering around the fatty tissue around the rectum, and remove it as one whole specimen. And that really improved the quality of surgery. Nevertheless, for many patients, they're still at risk for recurrence if they don't get radiation. And so for all of our patients here, we'll end up staging them with an MRI of the pelvis in advance of surgery. An alternative to this is a rectal ultrasound to look at the invasion through the wall. What you can see here is a MRI, again in the same orientation. So the front of the patient is here, back of the patient is here. This is their tailbone, this is their bladder, and this is their rectum. And down here is the anal canal. So if I just highlight the tumor here in blue, you can see it very well on MRI and delineate the location of this very well. This tumor is far enough away that the surgeons can make a cut through the rectum and reattach things, and they don't threaten getting near those anal sphincter muscles. But in other situations, when the tumor lies very low down in the body near the anal canal, then it's a situation where the surgeons often risk not getting enough margin to cut that tumor away without damaging the muscles and leaving the patient leaking stool, in which case a permanent colostomy is required. So this is an anal sphincter sacrificing surgery, often called an abdominal peritoneal resection, or APR. And so the difference with this is the first example. If we look at a different example where a tumor is lying much lower toward the anal canal, again, you can see it highlighted in blue, the tumor. This patient also, incidentally, has a lymph node sitting over here. Sometimes we can see those tumor deposits in the fat. That makes you higher risk for having a recurrence after surgery. But this is a situation where many surgeons would suggest that this patient, because of the proximity of the anal canal highlighted in green, would likely be at high risk for needing an abdominal peritoneal resection which includes taking those sphincter muscles and using a permanent colostomy. So how does radiation fit into this? So the general paradigm for patients that we treat here and at many other institutions in the United States is to start off with chemotherapy and radiation together. And usually what we're talking about is 5.5 weeks of daily radiation, Monday through Friday, not on the weekends, and taking an oral chemotherapy in the morning and at night. An alternative to this is an infusion pump of 5-fluorouracil. Then after they finish that chemotherapy and radiation, they usually wait about 6 to 10 weeks, and then will be taken to surgery and given a temporary versus permanent colostomy. Then about a month after that, they end up, if features on their pathology warranted it, getting additional chemotherapy for about 4 months. And at that time, often they'll take the temporary colostomy down. So that's the general paradigm here at University of Wisconsin. There's lots of variations in this around the country and around the world. And I'll talk to you about some of those variations and possibilities later. So what are the benefits of chemoradiation before surgery? Why do we do this before surgery in the majority of patients that fit that risk profile? So essentially the main benefit of it is the decrease in recurrence in the rectum or in adjacent lymph nodes. Often a pelvic recurrence of cancer is a very difficult situation to deal with. They are very difficult to salvage with surgery or surgery and radiation, although we sometimes do that. And often if patients who have metastatic disease have a recurrence there, and at some point they're not able to tolerate more chemotherapy, it can cause a particularly high amount of symptoms and discomfort. So we really like to avoid that situation of having a recurrence. The other major reason, and this is something that patients really jump on, is organ preservation. So are we able to convert somebody who thought they would need a permanent colostomy, abdominal perineal resection, or a sphincter non-sparing surgery, into somebody who may need a sphincter or may be able to get a sphincter sparing surgery? And there is some evidence from a trial called the German rectal trial, where that radiation did seem to, in about 1 out of 5 cases, change the mind of the surgeon who initially thought that they needed an APR and let them do change the mind when they thought they needed a sphincter taking surgery and changing it to a sphincter sparing surgery. So that's one of the reasons that patients like the most from this. And then also, often I'll get asked, why do chemoradiation before surgery as opposed to afterwards? And so in that same trial, they showed that there was less toxicity from the radiation if it was done in advance. Now, we certainly sometimes do chemoradiation in patients who have less advanced disease and went straight to surgery, but had evidence of cancer left behind. And so we certainly can do it, or had higher risk features on their surgery than they were expected in advance. So one thing I wanted to comment about is that radiation has evolved a lot. And one of the things that really drove me into this field was the ability to shape where the radiation was delivered. And so modern radiation can use something called intensity modulation, and it really lets you control the shape of the radiation dose better than ever before. One of the other things of radiation is just the image quality and the certainty that we're targeting what we want to hit when we target the radiation has improved a lot. So if we're uncertain about the patient's position on a daily basis, we can do imaging on the treatment machines that reassures us that they're in the proper position, that we're targeting what we want. And I'll show you some examples of that as we go along. Now during treatment, this has evolved to even involve MRI imaging during radiation, which we'll talk about at the end of the talk. So this is just a schematic from one of the company vendors that shows intensity modulation. And what these are what are called multi-leafed collimators. So they're thin blades of tungsten that slide relative to one another and are able to block portions of the radiation beam as it's delivered. So this is a beam or a slide where the radiation is coming from the top of the screen, going through these metal slides that block portions of the radiation and creating various shapes down below. And so the accumulation of these shapes during a treatment can create a radiation plan that is shaped. And so this is a patient where we ended up utilizing intensity modulated radiation because of concern for hip sparing in this. So one of the potential risks of radiation is radiation dose to the hips, and as we age, hip fractures or fibrosis of the hips. Also avoiding skin toxicity. Bowel toxicity is one of the major benefits for this. We use this sometimes in rectal cancer, and sometimes we use standard three-dimensional radiation, which gives very good quality plans. And so it's sort of the selective use of this technology that really helps. So one of the big benefits of radiation before surgery, as I mentioned, is the decrease in local recurrence after surgery, and it cuts that by about half. Organ preservation, the ability to avoid a permanent colostomy in 1 out of 5 patients. Having less toxicity if the radiation is done prior to surgery. And then also that we can avoid toxicity when the fields are large or if there's an anatomic change in a patient by using some modern techniques. So one of the big questions I always get are there situations where the patient doesn't need radiation? And yes, there definitely are. So very early stage cancers, so what we call a T1N0 lesion, I would suggest we don't do radiation. Most T2N0s, sometimes intermediate stage. And it really depends on the location of the lesion and the specific position. The other question I get is, what about a permanent colostomy? Do I really need to have this? And so these are actually both questions on borderline situations where we are currently doing investigation. I just wanted to touch on that because it's such a common question from patients. So there are certain patients who, by their size criteria of their tumor and location, we might ordinarily offer them radiation, that we might not. And then this other question of do I need a permanent colostomy? There's certain patients, as in this example that Moss et al. Showed in the Journal of Clinical Oncology, where they have such a good response that they wonder, how much benefit are we adding with surgery afterwards? And if it was a patient who needed a permanent colostomy, maybe we could avoid that. So again, these are questions that we're asking ourselves right now and not sorted out. But this is a picture again of an MRI where you can see a tumor here in figure A, and then this is in figure B is the colonoscopy image of that tumor. And then post-treatment, you can see by MRI as well as colonoscopy, there's really no residual evidence of the tumor clinically. Now, there certainly could be risk of microscopic disease there, and traditionally, that's how we have treated it. So there are certain groups now that are actually looking to see if some patients could avoid surgery. So, and this is really a question where the verdict is still out. So there's really no randomized data, which is what we consider the highest quality data. There is some long-term data out of Brazil where they seem to show reasonable outcomes for patients that had a complete response and would follow them and only do surgery as a salvage. These patients were getting regular surveillance. And that's probably the biggest, most difficult part, is how often to surveil people and how to do that. Memorial Sloan Kettering Cancer Center has looked back through their data and is now conducting a randomized trial of chemotherapy and chemoradiation, and for patients who have complete responses clinically, doing very active surveillance on them and postponing any potential surgery. And there's also prospective data from the Netherlands suggesting that that might be possible in highly selected patients. So the way that potentially can work is to do chemotherapy and radiation, followed by a sort of a later evaluation, 8 to 12 weeks, to get the best chance of a complete response, evaluating the response. And if you have a complete response, undergoing very close surveillance with colonoscopies, physical exam, as well as MRIs. But if you have an incomplete response, then going to surgery and potentially salvaging any recurrences with surgery. And some of their Memorial Sloan Kettering trial uses chemotherapy before and afterwards. So again, I want to just reiterate that this is potential for the future. This is not something that we are currently doing here now, though in Brazil and in the Netherlands, they do some of this. And hopefully we'll have the data from the Sloan Kettering trial to really support that in the future, if that's possible. The other big question I get often is for the lowest risk patients, are they able to avoid radiation? There are some long-term side effects to radiation, one of which is the risk of causing a secondary cancer in the distant future. We're talking usually 10 to 20 years in the future if that comes, and it's a very low risk, but certainly a serious risk for patients. But also all the other risks like causing scar tissue or the morbidity of going through the radiation treatment. And this is some data from Dr. Schrag's group that was published in the JCO that's prompted an ongoing clinical trial called the Prospect trial. But that just showed that patients who had started out with chemotherapy and had very good responses and omitted the radiation were able to have a very good disease-free and overall survival. And so this prompted a trial that's now looking specifically at this. So essentially patients are randomized to either starting with the standard path on the bottom here, which is chemoradiation followed by surgery and then additional chemotherapy, versus starting with chemotherapy. And if they've got a greater than 20% response, going straight to surgery at that point and not doing the radiation, the chemoradiation portion of it. Versus if they don't have a good response up front, less than 20%, then they would continue doing the bottom path here, chemoradiation, followed by surgery and additional chemotherapy. So these are really for only the most favorable patients right now, but that's an ongoing trial that we actually have open here at University of Wisconsin, is open across the country at multiple centers. And hopefully this pans out, that some patients are able to have less therapy and still have good outcomes. Conclusions from the rectal side of chemoradiation. So chemoradiation really does decrease pelvic recurrences and optimizes the chance of anal sphincter preserving surgery. And omission of radiation and or surgery are both really unanswered questions. And these are currently being investigated in randomized clinical trials in appropriate patients. So I don't want you to take from this that, hey, this is something that actively we're doing, but these are questions that I'm constantly asked by patients, and I know patients really want to know, is there any way or any work in this area? And so that's why I raised it. So what about stage 4 disease? Often we use radiation for palliation of pain or other situations, but there's also situations where colorectal cancer is relatively unique, where there is potentially curable stage 4 disease. So some patients with limited burden of metastatic disease, typically in the liver or lungs, surgical series have shown that if all those areas can be addressed, there can be up to 20 to 40% of patients could have a 10-year survival when all the metastatic disease to liver, lungs could be resected. So this is very different than we traditionally thought about stage 4 solid tumors. And part of this is probably that colorectal cancer is a different disease. Part of this is because the systemic chemotherapy treatments in colorectal are more effective than some types of chemotherapy in other diseases. This view on the left here is essentially looking at surgical salvage in rectal cancer that a physician named Joel Tepper published in 2003 that showed patients who had isolated metastases in lung or liver or elsewhere that were resected had better outcomes than patients that weren't. So that's a retrospective look at prospective clinical data. So what about radiation? Well, there is some evidence that for those patients who have limited, so this is a publication by Bay et al. That looked at patients with single metastasis to the liver that were not able to be resected, and showed that they can have, with stereotactic radiation, a very good overall survival and disease-free survival. This one only goes out 5 years, but there are several series that suggest this as well. And so that's what I wanted to discuss now, was colorectal liver metastasis for patients who either can't undergo surgery or choose not to and want a less invasive option. Stereotactic radiation is a treatment that we can do to the liver for a limited burden of metastatic disease. So this is a patient, and we're looking at an MRI here, a cross-section through their liver. And you can see on the right side of the liver, so just to orient you, I've listed, this is the patient's front, their back, their right, and their left. So their feet are sort of sticking out of the screen at us, their head is into the screen, and we're looking at their liver, which is this organ right here. And this dark area is a large colorectal metastasis. Out of the plane here, there's actually a small second satellite metastasis. And so this is a patient who was elderly, and we elected to treat with stereotactic radiation. That involves 5 treatments of essentially laying flat on a table, and a machine moves around you, delivering X-rays from different angles. So it's non-invasive and generally well tolerated. Mainly fatigue and nausea are the 2 potential major side effects. This position of this tumor is fairly near the kidney, which is here. So you can see the radiation is shaped to minimize dose to that portion of the kidney and maximize dose to the lesion. These are sort of like a topographical map, if you've ever seen one, where we're going up, the lines represent different elevations in dose. So as you get to the center, these pink lines are very high dose, and as you get further out, we're trying to avoid dose to the skin surface, to the kidney, to the remaining liver, to the spinal cord, to other organs. And so this patient had a very nice response 6 months post-treatment. You can see the pre-treatment over here on the left side of the screen, and there's the volume on the other side. It's shrunk down to less than a centimeter essentially in size. And and so they also tolerate this really well. So that's one of the great things about this type of treatment, is just in general, the tolerance of this is very good. You can see on the post-treatment scan over here, not only has the tumor shrunk down, but you see this sort of general intermediate haze area around that. That's actually radiation effect on normal liver. So that is liver that's probably not functioning anymore because of the radiation damage. It's not taking up that contrast dye as well as the areas outside of that. But the liver is a very unique organ, and we can cut away or damage portions of it, and the remaining liver will actually compensate for that rapidly. So as long as don't need to treat through too much liver, we can do this safely and effectively. This is a prospective trial that was run at the University of Colorado a number of years ago, which included patients with metastatic disease to the liver, where they treated with stereotactic radiation. All these were done in 3 treatments. This included both colorectal and non-colorectal. The colorectal made up the majority of patients. And on the left, you can see the local control for lesions here was in the 90% out several years. So they had very good local control at these doses. This is the type of treatment we use actually for patients with primary lung cancer that's then been adapted to the liver as another organ. And they're using doses here that are very similar to what's used in lung cancer. The other thing, they split this up into larger tumors greater than 3 centimeters and ones smaller than 3 centimeters. And the control rate for the smallest tumors, obviously, as you can see here, is excellent, 100%. What about other sites? So colorectal cancer doesn't often go to the brain, but I've seen several patients who actually have had metastasis to the brain. This is one such patient. And this is, again, a slice, an MRI through their brain. Their front of their face is actually on this side, the left side of the view, and the back is right here. And at the very top, you can see this brighter area that's enhancing with the contrast that was given, the arrow pointing to this. You can also, on a different sequence, see that there's lots of swelling right around this. That tumor was causing so much swelling that it caused them to be admitted to the hospital, unable to speak. So for colorectal metastasis like this, for this type of patient, the best option is surgical resection right away to decrease that compression. And that's what happened for this patient. For patients who would present without those symptoms, stereotactic radiosurgery would be an option. But for this patient, they actually, by taking them directly to surgery, they were able to decrease that pressure. But the surgeons can't take normal brain around the area to get all the cancer cells, so they can get the majority of cancer out of the brain. But there's a very high risk that that comes back just in the same location if they don't undergo a treatment. So for many patients, we will give additional radiation in a focused manner to the location of the brain metastasis cavity. And so this is what this patient underdid. Again, tolerated it very well, a little bit of fatigue. Some patients get a little nausea, but again, almost a year later, this is how that patient looks in a similar treatment. Doesn't have any noticeable long-term side effects. And so for a non-invasive way to sterilize the remaining surgical cavity, this actually works really well. Because colorectal doesn't go to the brain very often, we don't see a lot of colorectal cancer patients, but it certainly can, and many people aren't aware of that and think about it very often, but I've seen it several cases. This patient is asymptomatic and doing well and actually continuing on FOLFOX for their lung disease. Unfortunately, these effective chemotherapies don't cross the blood-brain barrier very effectively, which is why we end up using radiation. What about patients with metastasis to the lungs? So this is another patient that underwent, initially had a rectal cancer. They underwent rectal surgery and partial liver resection. They had multiple recurrences. They had ablation procedures in the liver. They didn't tolerate systemic chemo and then presented with sort of an isolated recurrence in the lung with an adjacent lymph node right by this that had been enlarging. And so this recurrence in the lung was not amenable to the procedures they had before. Certainly, it's possible to surgically resect this, but very difficult, and they probably would lose a lobe of their lung, so they weren't interested in that. So we ended up offering them stereotactic radiation. We do this a lot for lung cancers, not as often for lung cancers that have a mediastinal lymph node, but I ended up treating this to a very high dose to the portion that's in the lung, as you can see here, and then a sort of a moderate dose to that area in the lymph node, trying to avoid the trachea and the esophagus down here. And again, this was very well tolerated. And again, a very nice clinical response. A year and a half later, off of systemic therapy, they still are disease-free. So this was one of the more satisfying cases that we do. Those are just the arrows sort of showing. So basically what I wanted to give you an example for this was that stereotactic radiation is a very effective treatment option for metastatic colorectal cancer patients to varying sites. And in my view, it's actually often underused. It's very nice because it's non-invasive, it's extremely well tolerated, and it's very effective. It is not a substitute for other treatments. The reason that these local treatments do so well is because of how good the systemic treatments with FOLFOX, FOLFIRI, Avastin, and cetuximab have been. Okay, so let's switch gears. I wanted to talk to you a little bit about something that I've been involved in recently. So one of the things that's made modern radiation so much better than it was 20 years ago is really the image guidance. And we went from using no imaging to using x-rays to using what's called a sort of a modified CAT scan during treatment. And now the next evolution of that is MRI-guided radiation. And there's MRI-guided radiation treatment units now coming out and being adopted. The University of Wisconsin-Madison was an earlier adopter of one of these units. This is actually a treatment unit that delivers radiation while imaging with MRI guidance. And so under the covers, this was initially made with cobalt sources. They weren't able to make a LINIC or linear accelerator, which is what we typically deliver radiation with, compatible with an MRI. And so initially, this is an MRI that's sort of been split into two sides, one side here and one side here, and then a rotating ring. The patient lies in the middle of this, and that ring can rotate and deliver radiation from 360 degrees. This is actually currently undergoing, it's been approved for use now with a LINAC version. And so that is actually going to be coming in here in the next few months. So I think we'll have all the advantages of MRI with all the advantages of LINAC in the near future. So why do we care about MRI? Well, images I've showed you in the liver use MRI, and this is an example of a patient with one of those modified CT scans on the left side that we use. They're very good for aligning bone, but it's very difficult to see some of the structures in the abdomen. Breathing motion and gas in the bowel causes a lot of artifact. You can see the kidneys here a little bit, and maybe the outlines, the beginning of the outlines of the liver. You can see how much more detail you see here. The liver is well seen, the gallbladder, intestine, the duodenum there and there. You can see this lymph node sitting right here, the vasculature. So the better we can see, I think the better we can treat in most situations. One of the analogies I like to give is that shooting blind free throws, the record is, I think it's near 100 or so, and shooting free throws with the blinders taken off, the record's 3,000 something. So we just do a better job when we see what we're doing. This is an example of a liver metastasis being treated with radiation under that guidance. So this is what we see when we're actually delivering it. So this is in red is the patient's lung. The tumor here is being outlined in green, and the red is the radiation portal. So that's where the radiation is going to go. The liver's highlighted here in gray. And so if I just start that movie again, this patient's actually undergoing treatment. They're holding their breath and holding that tumor in exactly the right spot, and we can confirm it's in the right spot as they're going through treatment. So this is a stereotactic treatment to the liver. Now the patient, when they need to take a breath, they go ahead and catch their breath again and breathe. And then whenever they're ready again, they go ahead and take a deep breath and they hold it again. So you'll see this patient in a second try and reset the tumor. Sometimes the tumor doesn't set up right. Like there, the radiation automatically doesn't come on. We tell them through the headphones, let out a little bit of air. They can move the tumor back into the right position, and we can restart the treatment. So this, I think, really confirms the accuracy of the treatment. This in the middle of the liver helps us avoid a dose to the remainder of the liver. So if the patient was free breathing, we might need to treat a larger version of the liver. There's other means to do this without directly seeing, but this is the only situation I know where you can directly see the tumor, not rely on implanted fiducials or other surrogate ways of knowing that the tumor is in the right position. This becomes more and more important the closer to risky structures that we can damage with radiation become. So I think that as we get further on, the MRI guidance will enter our field more and more and more, because the soft tissue resolution is so much better that it really does improve the potential for accurate alignment and targeting, and really gives the treating physician confidence using very high dose near critical organs if they can see that that organ is not being directly hit by that high dose of radiation. As I mentioned, we can have the patient, we can manage motion directly with this technique, having patient breath hold and directly tracking the tumor to decrease the normal tissue dose and increase the tumor dose and improve the image quality as well. One other unique aspect about this is the ability to watch during treatment the response of the tumor. So if somebody's coming for a few treatments, we don't see a change in the treatment. But if somebody's undergoing rectal cancer treatment, where they're coming for 5.5 weeks, we can look midway through treatment and see if there's been changes in the tumor size. So this is an example of that. This patient's tumor sits here in the rectum. So this is the rectum here. This darker area is the tumor. You can see it on different views, and midway through treatment we can see some change in the size of the tumor. So this is not something we are spending a lot of time right now adjusting treatment on, but one of my hopes is that we can start to predict who is going to have a complete response to care and help dictate further care. We know that patients that have a complete response to chemotherapy and radiation have better overall outcomes, and so this may help us predict and then potentially even adjust therapy based on the response. We get these images free if we're treating using them every day to align. It's nice to get some biologic information from that too in terms of how someone's responding. So again, back to metastatic treatment. The take home from this is that colorectal cancer is unique in that some with aggressive treatment to either resect or treat metastasis, that we actually can make a significant impact in patient survival. I think SBRT does show potential for long-term survival in unresectable patients. But even with this, unfortunately, most patients in this situation are still failing. If we're getting 20 to 40% with surgical resection out to 10 years, that means that 60 to 80% of the patients are recurring. And we really want to know how we can improve upon this. So one of the most exciting things is, as I'm sure many of the listeners today are interested in, is immune checkpoint inhibition and essentially releasing the brakes on the immune system. This is just a diagram of one of the more targeted axis, which targets T cells and their interactions and uses a drug to block the interaction between this molecule PD-1 and PD-L1 and essentially potentially improve the outcomes of patients. This works really well in patients with with mismatch repair deficient cancers, and actually has been FDA approved not only in colorectal cancer for mismatch repair, but any solid tumor that has mismatch repair. This PD-1 inhibition has been approved for. But unfortunately for metastatic patients, they really, mismatch repair deficient really makes up only about less than 5% of the metastatic patients. And so it's really these mismatch repair proficient patients that we want to know how we can move up on that axis. And so a lot of the interest and work that I've been doing is to try and see if radiation in conjunction with immunotherapy can lead to better outcomes. So what are radiation effects on the tumor? Well, there's lots of different effects, and we don't know what here is important, but certainly there's a lot of research going into trying to figure that out. So radiation does create a lot of new mutations. It also causes various antigens or proteins that are not normally seen by the immune system to be expressed and potentially create targets for the immune system. It also causes a lot of dying cells that then release those antigens to the immune system. It triggers inflammatory cytokines. These are chemicals that are released by that cause the immune system to react more, as well as chemokines, which are chemical attractants to immune cells to bring them into the tumors. And then the other thing that it potentially can do is actually remove some of the immunosuppressive properties of the tumor microenvironment, so immunosuppressive macrophages and regulatory T cells. And that some research that was done in the lab by one of my colleagues, Zach Morris, prompted me to be very interested in treatment with radiation in the setting where all of the gross disease is addressed or removed. And so that, as well as my conversations with Dr. Dusty Deming, led Dusty and I to create a clinical trial of radiation, SBRT, and immunotherapy in colorectal cancer patients with liver-confined metastasis and completely resectable disease. So these are patients who essentially have tumor that spread from their primary to their liver, or have gone through various other therapies and are in a situation where they're left with just liver disease that can be resected. And these are those situations where we feel that we can potentially have good long-term outcomes to 20 to 40% of the patients, but we also know that the majority of these patients still do fail. And so these patients essentially, this is sort of the enrollment schema, basically with liver-confined metastatic colorectal cancer disease, they can have had other treatments, but if they can have all their disease cleared and has at least one lesion amenable to SBRT in the liver, then and they have microsatellite stable disease, then we can enroll them. So the goal is to really trigger a better immune response to any micrometastatic disease that we just don't see behind. And so the way this schema of this trial is to actually deliver SBRT over the course of 2 weeks, then 2 weeks later initiate pembrolizumab, which is anti-PD-1 inhibitor, and then 2 weeks later they go to operative management to remove the gross disease. Hopefully we have triggered a better immune response at this point against cancer cells, and by removing the gross disease, we not only give them the benefits of the operative therapy, but we remove any potential for immunosuppression from other lesions within the liver that either weren't targeted with radiation or are capable of suppressing response. And then they continue on pembrolizumab for 8 cycles. There are some other optional portions of this. So all patients will get PET MRI imaging at various points to see if that can help predict who's going to respond well and who isn't. We don't know at this point whether that could. And then there's also a separate type of a PET that some patients in this are getting called an FLT PET. And this is just an example of PET imaging. Again, we have an MRI here on the right side. You can see a single lesion here. This is actually a cyst over here. But this is very metabolically active. And we're lucky at this institution to have one of the few MRI PET combined machines. And so Dr. David Kim has taken a lot of interest in research projects with this machine as sort of optimize these for this protocol. So conclusions. We know from basic, from individual patient situations, some of them highly publicized, but some others, that radiation can stimulate a T cell response in tumors, and in particular colorectal tumors. The trial that we're using here is actually trying to use this effective radiation with this immune checkpoint inhibitor to really attempt to help the body recognize the colorectal cancer as foreign and attack it. Historically, colorectal cancers have not been so-called hot tumors or very recognized by the immune system, except for the microsatellite unstable. And so hopefully we're able to convert that. And then also the surgery after the stereotactic body radiation therapy is to clear any remaining metastasis, as well as the one that was treated, and give the immune therapy the best chance to work against the least amount of burden of disease. We're very excited about this. This is a phase 1 trial, really establishing safety for this. But if it does prove safe, then hopefully we'll be able to move it into larger trials. So overall, I think radiation does play an important role in the management of colorectal cancer, particularly in localized rectal cancer, but also in metastatic situations for metastatic lesions, both in the lung and liver, but also the brain, as well as some situations in lymph nodes. It really can be an effective non-invasive treatment. Also, MRI-guided radiation treatment does allow, I think, the accurate treatment of allows accurate treatment, as well as easy assessment of response during treatment. That response during treatment is one of the things I'm actually the most interested in, because it really allows us to potentially individualize or tailor the radiation therapy. Right now, we give everybody the same dose to the same number of treatments, but we certainly could adjust that. We just don't know how to at this point. And so that gives us a lot of information that we potentially don't have up until this technology is available. And then what says immunotherapy, but should say immunotherapy, is very exciting. I think it's probably the most exciting thing in all of cancer care, because it really had not been a big part of it up until a few years ago. Unfortunately, it's still ineffective for the majority of colorectal cancer patients. And we and others are really looking for ways, other drugs or radiation or other techniques to help the immune system target colorectal cancer. So thank you. This is just an image of my department here at Department of Human Oncology at the University of Wisconsin. And all this treatment is really dependent on a large staff of physicists, therapists, administrative staff, and doctors. And so it really is a team effort to get this through. So thank you, and I'm happy to take any questions.
Thank you, Dr. Bassetti, so much for a great presentation. Let me just change over the slides real quickly here. Okay. So again, a reminder to go ahead and type in your questions. Hold on just a moment. I think we're having some issues here with the slide deck. There we go. So just a reminder to type in your questions on the right-hand side of your control panel if you have any questions. We did have a couple that came through. So Dr. Bassetti, our first question is there a maximum lifetime radiation, or is it per person or specific per area of the body? And can you maybe explain that a little more?
Yeah, that's a very good question. So certainly there are limits to the doses of different tissues that they can tolerate in terms of radiation. And that's how most of the doses that we have derived come up from. So how much can we deliver without causing serious complications or harm? And there is potentially a limit, although I will say that it used to be if you gotten radiation before, that we would never do radiation again to the same area. So really it is area dependent. So if you have a recurrence in an area that's had radiation before, I am often delivering radiation to those situations, but it makes it a higher risk treatment. And it's certainly on a case-by-case basis of whether we can do it. And it really, when we say a lifetime issue, we could certainly deliver the radiation again. It's just a question of what the risk of complications and serious side effects from the radiation are, and those side effects go up with retreatment.
Great, thank you. We do have a couple other follow-up questions. Some of the trials that you showed earlier in the presentation were older. For example, the TEPR study from 2003. Have there been additional studies that show the same or better outcomes?
Yeah, that's a very good question. So So yes, there are lots of studies. So the TEPRA one is one of the first or earlier ones to show the outcomes of patients who have had resection surgically. But yeah, over the years, every few years, people will update these series of patients that have gone through surgical resection. There's one trial that has over 1,000 patients in it, and that's showing very good outcomes from 10-year long data. But yeah, there's multiple series of trials that show that that surgical resection can lead to good 10-year outcomes. There's less series like that show radiation, just because it's a much more newer technique, that focused radiation, stereotactic radiation to the liver. But there are some that are showing very good 5-year outcomes. And so usually our focus is to take patients through a surgical resection of any liver metastasis if possible. And if unresectable, then radiation would be a second option. There also are numerous older trials for rectal cancer, which I didn't really show a lot of, but there are definitely more contemporary trials as well. But almost always our data for randomized trials is 5 to 10 years behind, because it takes a long time to accrue them, and then we have to wait many years for their outcomes to happen. So we're constantly updating those, but the outcomes we give you are always going to be behind to some extent.
Okay, great. Thank you. We will keep our eyes peeled for the latest. Another question we have, what steps do you recommend for a patient? What steps do you recommend for a patient to do to prepare for their first radiation treatment? Is there anything that they can do to reduce potential side effects?
Yeah, that's a really good question, and actually one of the more common ones. So, I think the radiation treatments in general, depending on the site of treatment, the side effects vary. So there's not a ton that patients individually can do, except for the fact of reading up the material that they're given, maintaining good nutrition coming in. So, one of the side effects of rectal radiation is that can cause loose stools or diarrhea. So, if you have trouble with certain foods, avoiding those foods, try and not potentiate those. The radiation treatments to the skin, sometimes people are concerned about irritation of the skin. Certainly on calendula lotion has shown some benefit in breast cancer situations, and so using either that lotion or other lotions sometimes may have an impact. But there's also some data that suggests that they actually don't have a large amount of impact. So we're really sort of counseling patients on an individual basis of what is most comfortable for them. I think the biggest thing about radiation is that there's a lot of anxiety involved in it. We spend our lives somewhat avoiding exposure to radiation, wearing sunscreen, not wanting to get exposed, and I'm the same way too. But so there's a lot of fear of it. But in general, I think it actually tends to be one of the better tolerated treatments.
Thank you. I know we're close on time, so I'll just ask one final question, and it's about palliative radiation. Is there a role in colorectal cancer for palliative radiation treatments?
Yes, definitely. So many patients I see that have pain, often bone metastasis can cause pain, or a tumor can cause obstruction of either ureter or of bowel. Those are the situations we often can treat. Bleeding from colorectal cancer is another common one. 3 to 5 treatments of radiation that are very well tolerated can often stop bleeding very effectively. And so those are very common situations, and we treat a large number of patients specifically for those situations.
Great. Thank you so much, Dr. Bassetti. This was a wonderful presentation, really very thorough. I learned a lot. I hope that the attendees were able to learn a lot as well. Again, for everyone that's tuning in, if you'd like to re-watch the webinar, it will be housed on our website. So you can find it there and log in and watch at any time. And again, Dr. Bassetti, thank you so much for your time today and for sharing all this wonderful information with us at Fight CRC.
My pleasure. Thanks for having me.
Thanks. Bye-bye.